Hi, everybody. We're here from the American Association of Suicidology Conference here in Phoenix, Arizona, and I'm really excited to be joined by Dr. Tony Pisani. He's with the University of Rochester and is going to tell us a little bit about some of the work he's doing with the Zero Suicide movement today. Welcome, Tony.
Hi, I'm happy to be here.
Great. Can you tell us a little bit about your work at the University of Rochester, your role, and what led to you being involved with this work?
Yeah, I'm on the faculty of the University of Rochester with the Center for the Study and Prevention of Suicide, also part of the School and Community Prevention Laboratory. And my work spans the suicide prevention continuum. So I do some work that's really upstream prevention in schools, communities, and now in the military as well. Then also do work in clinical settings and healthcare and trying to help both individual clinicians but also healthcare systems to provide suicide-safer care.
Like you said, for today we're going to focus a little bit more on some of your clinical work, but of course we'll include some links to some of the great upstream work you're doing as well. First, let's just talk a little bit about Zero Suicide, what that movement means, and what the name means to you as well.
The aspiration is what we all want and care about, right? I mean, every suicide is one too many. Sometimes I wish it had a different name because my experience is that for many clinicians, especially if they're used to being in a system where there might be fear or the perception of blame, I think people hear zero suicide and they think, oh, great, so now I'm going to be blamed if there's any suicides. And I don't think that's at all the intention of the movement. And in fact, it's exactly the opposite. It's designed to not put all of the responsibility on one person, but rather have a system of care and a safety net there. So it's actually the opposite of the intention, but I think sometimes the effect is kind of chilling. And so there's a lot of sort of explanation that has to take place for people to get on board and feel like, okay, I can be part of this movement, that this is going to be about supporting me in doing this, important and hard work of helping people, past and into recovery.
Absolutely. And again, thanks for being on this with us today to help explain that and explain what zero suicide is and also, like you said, what it is not, which is not a culture of blame. It's really a support system across many levels of healthcare. Let's talk a little bit about some of your work. I understand you developed a program called Commitment to Living. Would you explain that a little bit for us?
Like many of us in the field, sometimes we come to suicide prevention after tragedies. And I was directing a clinical service, and in the course of 3 months, we lost two patients to suicide, an adolescent and an adult. It was really so painful, both the human loss but also to see the clinicians that were working with me go through both grief and fear and anxiety, and as well as, of course, for the reality is when as a clinician survivor, there's the added complexity of the administrative scrutiny and other things that come in the wake of a suicide. So it's a very complicated grieving process. Really didn't have a strong background related to suicide prevention in clinical settings at that point. So I began to try to learn everything I could and just started sharing what I was learning. Turned out that other people wanted to hear also the things that I was learning. And thankfully, because I was at the University of Rochester, I had access to just amazing people and resources through the Center for the Study and Prevention of Suicide. Some of the leaders in that center, invited me to be part of that center and then test and further develop this training that I had put together and a model of suicide risk. And that model continued to evolve over the years, through the benefit of talking with really tens of thousands of clinicians in many different settings, refining and changing that model over time. The model that I developed for risk formulation as well as for connecting with patients, explaining to patients how, kind of engaging them to consider their own risk, responding to that risk, and extending our kind of safety nets with patients. That has now become part of the Commitment to Living training, which we have both versions for mental health professionals and for primary care. That same model is also part of the Suicide Prevention Resource Center's assessing and managing suicide risk workshop, which I was fortunate to be able to work with the Suicide Prevention Resource Center and really strong people there who are now also heading up the Zero Suicide Institute, and to do a major curriculum overhaul of that already very good workshop to be able to put some of the ideas from Commitment to Living into that other national training.
Fantastic. I'm a little curious about the aspect of patients or clients considering their own risk. Could you tell us a little bit about what that looks like?
I guess from both a practical and a philosophical standpoint, I feel like it's important that not only can clinicians across different services and settings be able to speak the same language and have this common sort of mental frameworks for assessing, responding to, and communicating about suicide risk amongst ourselves and in our medical records, but also I feel like that same framework should be transparent and able to be communicated with patients. A key part of my approach in working with a healthcare system is helping them to use the models that I've developed to walk a patient through and collaboratively discuss how they see their own suicide concerns, and also sharing how we do, so that we don't not sort of making this up each time, but rather saying, let me show you how we think about the kinds of concerns that we're having and what kind of things we feel we need to plan for with you. And I want to hear how you see it. So let me show you this diagram, and maybe you can say, I'll share with you how I'm seeing these different kind of bubbles in this diagram, and you can share with how you do. So and so that now that shared framework, that common language is among the entire team, which should include the patient, just being able to explain this to families. Very important, especially in settings where there might be disagreement between a clinical judgment of a team or the ability of a team to put somebody in a certain setting. Maybe the family had a different opinion about what that is, so that we can just sort of explain to them, well, here's how we make these decisions, so that it's transparent and we're all kind of part of creating culture change is having a shared language.
So I really appreciate that this approach is very patient-centered and collaborative, and it sounds like you also involve the family.
So in addition to being a clinical psychologist, a licensed psychologist, I'm also a licensed marriage and family therapist, and really a key part of my identity is as a family therapist. And so I do feel that families need to know what their part might be. I think many families are very eager. Not every family is able to participate, just as many times when somebody is in crisis. They also collaborative has to have a pretty wide range, because based on what someone's really able to do. And I think that's some of the common dilemmas that I think are important to address in education, whether it's in the Commitment to Living training that was sort of the origin and foundation of these things, or assessing and managing suicide risk for the Suicide Prevention Resource Center. All those build in this idea of we have certain aspirations like collaboration, but it's a lot easier to say than to do. And so how do you match the collaborative spirit with what the patient is actually willing, able to do? And same thing with the family. And so sometimes collaboration might look a little bit directive, because that's all you can do. But then the point then for clinicians to know, like, well, so how do I do that with integrity? If my safety plan says at the top, collaborative safety plan, what happens if the person really is not able to contribute much to it at that particular time point? So that's the kind of things that we work on in education and in doing kind of practice transformation for systems.
So how do you help clinicians and the healthcare systems as a whole learn and implement your model?
Well, there's a number of steps. Just as in kind of zero suicide, a lot of these things begin with leadership. Often I will work with a leadership team or an implementation team to kind of be on board with a model. A key part of this model is shifting from the idea of putting people into risk categories. We're shifting from the idea of prediction-oriented suicide risk assessment to prevention-oriented. One common kind of mantra that I sort of share is the purpose is not prediction, it's planning. So the reason we have a risk formulation is to assist us in planning. And so our formulations are only as good as they can help inform what we do. So a first step is kind of making that paradigm shift into, okay, maybe I've been saying low risk, moderate, moderately high to low moderate, intermediately low moderate risk. And instead shifting to a contextually anchored risk formulation that says, well, risk compared to who? Risk compared to when? The first step in the education process, and usually people find it a great relief to make this shift from a kind of abstracted, prediction-oriented categorization into this kind of thinking about risk compared to who and risk compared to when. Risk within the context of the treatment setting where somebody is or might be considering to go, and the patient's own life. And we conduct a number of experiential exercises in the workshops that I've developed to help people first be able to communicate with a colleague, next to be able to communicate with a patient, and then third with the medical record.
That's great. I think that's such a critical point you just brought up regarding risk assessment, because there's so much, say, pushback. There's even a movement to abandon risk assessment altogether, and it's like so important to understand what risk assessment is actually trying to do, planning versus predicting. And I wonder if you could just actually emphasize that a little bit more for us.
I'm very sympathetic with the movement to try to pull this risk word out of our clinical vocabulary. I'm actually very, very sympathetic with it because I think it almost inevitably pushes people towards this idea of what I'm trying to do here is figure out, is this person going to engage in suicidal behavior, which is something we really can't do right now. Suicide is a highly predictable event in retrospect. Once somebody has died, you can see this sign and that sign and that sign. The problem is, if you were to look at 100 other people, they might have those very same signs. And so I'm very sympathetic with the idea of maybe we shouldn't even have this word risk in there because it implies a kind of statistical probability that we really are not very accurate at being able to do. So what we've instead tried to do, because I think that's a little bit of a too radical for many systems now to sort of say, well, we're not going to use that risk word at all. And so instead we've tried to anchor that risk conversation in context that can then drive planning and responding. And so in a way, we're sort of hijacking this risk concept and taking it out of its kind of probabilistic history and instead saying, well, let's use this to mean considering where the person's fit is within their setting, who might need extra resources. And let's look at this person's own life and recent history, and are there changes? And that's really the key. So even when we consider this sort of risk compared to when, the purpose is not to make some prediction about are they at more risk than before. It's really the real purpose behind it is get me thinking about, have there been changes for this person, especially changes that are in modifiable risk factors, so that I can cue in on those and address them with the person.
So we've talked about your risk formulation, and I've been reading some research and some efforts to really move the field forward in terms of our ability to predict risk. Do you have any thoughts on that?
I think that work is very exciting, and some important work is going on in the VA particularly, but also in all quarters to improve our ability to identify and predict risk in very short intervals. There's research going on for physiological measures, for trying to identify latent suicidality without relying entirely on self-report. I think those are very exciting, and I think there's a lot of promise out there. I think for the clinician working now, and even when we do get better at that, so let's say I did find that somebody that using a well-validated prediction model, I was able to know that their risk may have increased threefold for suicide in the next 5 days. Let's say we even got it that short. Or what if we even got it down to the next 2 days? We're still a long way from there, but let's say we really got there. Then what? We're still going to need a model for deciding what to do, because that will be data to inform a risk formulation. It'll be better data. So I think what those efforts can do is provide us with better data to inform but we still have to figure out, well, is this person going to require additional resources? what are the available resources? What are a couple of things, and this is a key part of our risk formulation called foreseeable changes or potential triggers. What are a couple of things that if they happened might make things even worse? And then make specific contingency plans for those things. So the need for formulation is not going away, but I'm excited about efforts to try to improve the data that goes into them.
Yeah, that's really helpful and actually helped clear it up for me where that predictive modeling fits in with risk formulation. Finally, I just wanted to turn to some of your work with primary care and the work you do to bring this outside of mental health and into general practice.
My roots are really in primary care. I completed my first fellowship was in primary care psychology, then later came to suicide prevention research and completed a fellowship in that as well. So we have adapted the Commitment to Living model for primary care. And in collaboration with Wendy Cross at the University of Rochester, who has a very exciting patient safety grant related to this, we developed a brief series of videos that we're now testing actually in 2 different federal studies to help train people in primary care on how to think through and respond to risk. So I think this is a really important area. One of our big aims was to get a training that could be completed in about 34 minutes, which is about will fit into sort of noon conference in primary care. And so in addition to that training, I'm also working with systems to implement changes to their systems in terms of screening and responding. But I really am very committed to the idea that we need to have people have a framework, a schema in their minds for how to think about, respond to, and communicate risk amongst us ourselves, with the medical record, and with patients themselves.
Mm-hmm. And primary care is a huge touch point for these patients, so it's a very important avenue to explore for suicide prevention.
And there's a number of exciting studies. In fact, one of the ones that we're part of, where a Commitment to Living for primary care is being used, is a study out of UC Davis. PI is Tony Pisani, who's doing a patient activation study for middle-aged men in primary care. The physicians that are going to be working with those patients are being trained with this model.
That's great. Well, Dr. Pisani, it's been so great to have you. Thanks for taking time out of your day at the AAS conference to come talk with us. Listeners, you can learn more about the exciting work and click on some links, and we'd love to have you back to sort of get some update.
I'd like to do that. I really appreciate your really thoughtful questions.
You're welcome. Well, again, thanks for joining us, and we'll talk to you next time for more important interviews on work in suicide prevention.